Well, thank you to the meeting organizers for the invitation to participate. I'm going to discuss some of the achievements of the Early Breast Cancer Trialists Collaborative Group. These achievements allow us to better understand what randomized clinical trials in breast cancer have achieved and perspectives on where we are going. Now, the Early Breast Cancer Clinical Trialist Group had a humble beginning. In fact, it was a small meeting in 1984 covered in one page in Lancet, but it summarizes in its first paragraph what its initial goals were. It said, no firm conclusions have previously emerged about the effects on mortality of adjuvant systemic therapy in early, i.e. operable non-metastatic breast cancer, and this might be partly because the results from many different therapeutic trials have often been considered almost in isolation of each other. So this is a great summing of the clinical trials that were available, many of which were so small as to be underpowered to show the effects we now know exist. Now, there is advantage to pooling your data. To pool and synthesize data between randomized trials that by themselves may be too small to yield statistically relevant results. Secondly, when you pool your data, it allows you to do subset analysis. Most, even large trials, are powered for the main effect of the primary endpoint, which is clinical efficacy, and have too many patients to test important questions in subsets of patients to allow real individualization of therapy. Now, there are some caveats about meta-analysis. One of them is that this summing gives averages, but averaging may obscure important features in the data. For example, not all polychemotherapies may have the same efficacy. We know that the benefit of some anthracycline-based regimens is significantly better than the early regimens, such as CMF. And some subsets may be affected by factors not controlled for, and there may be an illusion of differences. For example, in older patients, they appear to get less benefit, but is this because they're truly less responsive or because they're given simpler, less toxic therapy? A word on methodology. Most of the results are presented in tables showing outcomes as recurrence-free survival, breast cancer-specific survival, or overall survival. In the tables and forest plots, the results are often presented as hazard ratios. Now, a hazard ratio is the ratio of the events with therapy divided by the number of events without therapy. For instance, an 8% risk of a negative event with therapy, but a 10% risk of an event without therapy gives you a hazard ratio of 0.8. This allows the effectiveness of trials with different baseline risks to be compared. Another term that's often used in the overview is proportional risk reduction. And this is 1 minus the hazard ratio. If you have a hazard ratio of 0.8, the proportional risk reduction is 0.2 or 20%. Now, there have been a series of major publications dealing with the results of the Early Breast Cancer Trialists Group. These shows the dates of these publications. They roughly occur a few years after a summing of data and analysis which is initiated every 5 years. And you can see a gradually growing number of cases and trials included in these analyses. But I would like to point out that the 2008 analysis publication actually has fewer patients and fewer trials. And this is because of the fact that now the meta-analysis is looking at significant biological subsets of patients. For instance, this meta-analysis centers only on ER-negative patients. So let's take a look at some of the results over time. So these are the results for tamoxifen, and show that the results in red here for the patients that are older than 50 and blue for the patients that are younger than 50. And the striking thing from the perspective of today is that early on it appeared that tamoxifen had no efficacy in patients younger than 50. And this was an illusion, something that the meta-analysis eventually corrected. And the reason why there was so low efficacy is that these trials gave, most of the patients participating in these trials received only very short periods of tamoxifen. In fact, only about 10% of the patients received more than a 2-year program of tamoxifen. So it's not a surprise that the overall efficacy appeared to be only about 11%. Now, more recent data show that shown here at the top in black, the proportional risk reductions for recurrence and mortality, which are roughly 1/3. It also shows another power of pooling your data, and that is that it allows you to view the efficacy of therapy over time. So is the effect early and not late, or what is the effect of adjuvant therapy? And here you can see in the smaller numbers at the bottom underneath, the interval proportional risk reductions from years 0 to 2, 2 to 5, 5 to 10, and beyond 10 years. And what this shows is the well-known carryover effect. It shows that tamoxifen is not only effective for the 5-year period in which it's given, but it's effective for an additional period in terms of recurrence for the next 5 years. And then after that, it does not appear to be effective. And you can see the same kinds of things for mortality with a prolonged impact on breast cancer mortality. And these kind of results help motivate the trials that we're doing today that are looking at more extended periods of hormonal therapy, and show also the extended period that these patients who are ER positive are at risk for recurrence. So let's take a look at the proportional risk reductions, not for tamoxifen, but in this case for polychemotherapy. These are actually more stable with time. There's a gradual apparent improvement of polychemotherapy. This is polychemotherapy versus nothing. And it shows something that's well accepted today, that on average, older patients have less benefit from adjuvant chemotherapy. But we're going to look at this in a more individualized way as things go forward here. Now, one of the things the overview did is it very early on eliminated the interest in single agent adjuvant therapy. And you can see here that, for instance, single agent versus no therapy had a very low efficacy. And it was clear that higher efficacy was achieved by polychemotherapy versus no therapy, and that polychemotherapy was superior to single agent therapy. So all the recent analyses have concentrated on only polychemotherapy trials. This actually shows the results of the most recent analysis of all patients. And you can see that there is still this age difference, with the younger patients achieving about a 1/3 reduction, and the patients who are older only about 12%. Now, there are important differences between the efficacy of chemotherapy, however, that are obscured somewhat by this average analysis by age. In the younger patients, estrogen receptor status does not appear to be important, but it's well recognized that in the older patients, the ER positive patients actually obtain on average a very small amount of benefit. And here you can see that in the older patients, the proportional risk reduction in the ER poor patients is almost as good as the premenopausal patients, but for the ER positive patients, it's only 5% and not statistically significant. Now, before we write off the idea of giving polychemotherapy to postmenopausal ER patients, positive patients, let me show you another result from the overview, and that is the proportional risk reductions seen for the more complex regimens versus CMF, or simple regimens. And the overall proportional risk reductions for building off of CMF, and this is true both in premenopausal and older postmenopausal patients, is statistically significant. So in these patients are able to achieve benefit from chemotherapy, but it has to be with more intense regimens. Now, What therefore was new in the most recent publication, the 2008 publication from the meta-analysis. And what was important is evident in the title, in that it was looking at estrogen receptor poor breast cancer. This was a meta-analysis that focused on a specific subset of patients. And this actually shows the results by age in the ER poor patients. And interestingly enough, actually, as you break it down finer, it does appear that the older ER negative patients achieve somewhat less benefit than the younger ER negative patients. Now, what was missing from this analysis? Well, what was primarily missing that I think most of us would want to have most seen is more detailed analyses about the impact of anthracyclines and taxanes in these patients. So what was missing is the more recent advanced chemotherapy regimens. The other thing is, I think that we're really waiting most for the ER positive analyses, because it's in these patients that the therapy has limited effects, and we want to most identify which patients would benefit from such therapy. And there is molecular evidence that suggests that there's a difference in sensitivity between patients, for instance, between luminal A and luminal B patients. And so one of the questions for the meta-analysis is, can it identify subsets of patients that specifically have higher levels for which adjuvant chemotherapy has higher levels of efficacy? Now, they did re-look at the efficacy of tamoxifen in this analysis, and what they found was that for patients younger than 50 years of age, there was absolutely no evidence, even a suggestion of efficacy. Interestingly enough, there was a slight degree of efficacy in the older patients, even though they were ER negative. Now, what they call into question, and I think it's an appropriate question, is the accuracy of ER testing, and whether or not some of this low level of efficacy may be simply due to errors in ER status estimates. So the other recent results presented for the early breast cancer clinical trialists were the results presented at the San Antonio Breast Cancer Symposium of the efficacy of radiation, local radiation to the breast. There are 11,000 women that participated in 17 trials analyzed for breast cancer, breast conserving surgery versus the same surgery plus radiation therapy. And the median endpoint for these trials was substantial. It was 10 years. And this shows the results of that, which are no surprise. They're actually results that have been published in the past for the overview analysis, showing that in breast conserving surgery, that there is a net benefit, about a 2/3 reduction in local recurrence, and about a 10% improvement in survival for those patients who did and did not receive radiation therapy. They specifically also looked to be sure that the net benefit was seen in both node negative and node positive patients, and it was seen in both subsets. Something that I'll show you in a moment isn't so clear for mastectomy plus radiation. The other thing they did, consistent with a general theme of actually individualizing therapy and looking at patient subsets, is they broke the patients out by tumor size, ER status, and histologic grade to the degree of benefit they had. And there were a number of subsets that they looked at, but I'll just contrast the upper left here, which shows you the outcomes for patients who had a lumpectomy and were estrogen receptor positive and received tamoxifen. Now, these are patients at generally low risk and will have a lower net benefit. And you can see that for those patients, there were some patients who were identified, particularly the older patients who were ER positive and had low grade, that achieved very little benefit by the addition of radiation therapy. And this is contrasted to the patients on the lower right, where these were patients that were had larger tumors. And in particular, the young patients with high-grade tumors, radiation therapy was really substantially improved their outcome. Now, they did also look at the more controversial area of mastectomy plus axillary dissection plus or minus radiation therapy. There were roughly 8,000 patients, 20 trials, a median follow-up of almost 9 years. And this shows the results of this for the most controversial group that they looked at, and this is for the node-negative patients. And although benefit was seen in survival for the node-positive patients, in the node-negative patients, the recurrence risk was decreased, but the mortality was not improved by the addition of radiation. And I think that that result is a result that drives most of the guidelines today that recommend against radiating, chest wall irradiation for people after mastectomy if they're node-negative. Now, this actually shows the power of the meta-analysis. They're able to actually node by node look at the impact of radiation therapy. So they actually took a look at the subset of patients that has net benefit, patients with 1 to 3 nodes, and broke it out for patients with 1 node, 2 nodes, and 3 nodes. And as you can see here, that all subsets of patients actually had a mortality benefit. So it's only the node-negative group that was identified as achieving no net benefit from radiation to the chest wall after mastectomy. So in review, the most recent publications relating to the early breast cancer clinical trialists meta-analysis, the first publication, this is the first publication about systemic therapy that actually concentrated on a specific biomarker related group, the ER-negative patients. And it's a gateway to more interesting and numerous other subsets of patients. And in particular, I think we're all looking forward to the analysis in ER-positive patients. Now, what's new and relevant about the presentations looking at radiation therapy? Well, it just confirms the prior results of the breast cancer in breast-conserving surgery, that radiation does add to the outcome for these patients in both node positive and node negative subsets. In mastectomy plus radiation, it gives more detailed information that shows that for node-negative patients, there doesn't seem to be any benefit. But for patients with even one node that's positive, there seems to be a net benefit. So what are the next steps in the meta-analysis? Well, clearly to be relevant to the modern era, it has to actually address some of the subjects that are about to be addressed by the next two speakers. It has to actually analyze things not by pathologic variables, but by subsets defined by modern molecular profiling. And this would enhance its clinical relevance. Secondly, it needs to include modern questions relating to the value of taxanes, HER2 interacting agents, and other new therapies. And efforts are underway with the current analyses to incorporate these ideas and to move into these domains, a process that's underway. So thank you very much for your attention.